right, good morning. Good morning. We're going to go ahead and get started. It's my pleasure to introduce Dr. Lisa Carey this morning, who is this is a long one, the Carey Richardson Marilyn Jacobs Pryor Distinguished Professor in Breast Cancer Research. Coming from University of North Carolina, Chief of Hem-Onc there, Physician-in-Chief of the North Carolina Cancer Hospital, and I think more importantly, when looking at everything, national leadership roles in the NCI, Breast Cancer Steering Committee, a huge part of Alliance specifically for leading the breast cancer research there. Had a wonderful time getting to meet her last night, and feel honored that she's come to visit us and talk about neoadjuvant therapy.
Thank you very much. Hey everybody, it's an incredible pleasure to be here. It's been a few years, but I remember I actually stayed at the same hotel at the conference center the last time I was here, so it feels like I'm coming home again. So I have the pleasure of talking about neoadjuvant breast cancer therapy because that actually is kind of for us where the rubber hits the road in terms of research in early breast cancer, and there's a lot of attention. Here are my disclosures. They're all research funding, none come directly to me. So as I was putting this talk together, I actually got a text, from one of my favorite surgical oncologists about a patient that we share. And so he texted me that the sentinel nodes, he'd done a staging procedure on the sentinel nodes. He said they were positive. 2 out of 2 were positive. And I'm going to call her, but I think we should do neoadjuvant chemo so we can see whether the drugs are working. So I think that's very, it was a great chance to kind of leverage the clinical question and is my dear surgical colleague correct? Is this a good use of the neoadjuvant model? And what do we know about endpoints in neoadjuvant therapy specifically? How do we know when it's working? So this is a well-studied phenomenon a number of years ago. The big question was, is it better to give the drugs before surgery or after surgery? And the short answer, and you can see the disease-free survival, distant disease-free survival, and overall survival curves, and I say that carefully, curves. You can't really tell, but there are actually 2 curves on each of those Kaplan-Meier graphs of same drugs, same doses, same schedule. The only thing that changed was timing vis-a-vis surgery, and it doesn't matter, right? From the standpoint of long-term distant disease-free survival, which of course is what we care about, and overall survival, it doesn't matter. So that's given license to do a lot of therapy in the neoadjuvant setting, particularly neoadjuvant trials. And there are some real clinical benefits and certainly some research ones. So this is an example of everybody kind of endorsing this conceptually, particularly for trials, and it's, it kept going in 2016. I forgot to update this slide. But the fact is there's a lot of interest in using the neoadjuvant model for testing of regimens. So what can we say about endpoints in neoadjuvant therapy and whether we have a lot of faith in them or not? What can we say about the endpoint? So neoadjuvant drug therapy, shrinking the tumor, that's an obvious clinical endpoint, and it's very real. You can buy time for surgical decision making. That's not an uncommon reason for patients to undergo neoadjuvant therapy if you're sure about that, what drugs are going to be given, but the patient and the surgeon are uncertain about what surgery is going to be done. You can buy time by just going, we go first. Now, then there's the intermediate endpoint for survival, which I'm going to talk about. That's a research endpoint, right? That's not really a clinical endpoint, and you can acquire tissue for biomarkers, incredibly important and definitely research. So let's talk about each of these. So one benefit, you have smaller and you have better informed surgery. So you can shrink the tumor. You clearly can take patients from inoperable to operable. You can take patients who are only a candidate for a mastectomy to being candidates for lumpectomy if that's desirable, and you can achieve a better cosmetic result. And you can see a picture on the bottom of a tumor shrinking with therapy. So how good is this? So actually this is a data set from, we call it the Alliance now. These are actually 2 legacy CALGB trials. And actually, when we were developing these 2 trials, CALGB 40601, which is in HER2 positive disease, and CALGB 40603, which is in triple negative disease, they were asking different drug questions. But while we were developing, the surgeons were going around in circles about what was going to be the mandatory surgical approach, and nobody could quite agree on it. So we said, fine, let's embed a surgical sub-study with prospective ascertainment of surgical endpoints, and let's answer some questions about what are the practice patterns and what are some of the obstacles and the benefits in this setting. So this was actually just published. This is the merged data set from those two studies. It ended up being about 700 patients, so it's a very large merged thing. And in that study, pre-therapy, the surgeon was asked, is this patient a candidate for breast conservation, yes or no? And then after therapy, they were all again asked, is this patient now a candidate for breast conservation, yes or no, and why? So what you can see is if you just look at the no's, right? If they're a candidate for lumpectomy up front, then typically they remained a candidate. It's unusual for tumors to progress during neoadjuvant therapy. On the no category, about half of them no. After therapy, about 42% of those had converted. So that's a real benefit. A patient who wants to have a lumpectomy was not a candidate, became a candidate. So now if we look at the initial non-BCT candidates, that 42%, 151 again, of those, not all of them attempted it. The patient decided, no, I'm going for bilateral mastectomy or whatever. But of those that attempted it, it was successful in 85%. So this is a real conversion. Now here's the however about doing that flip-flop. It's not without some risk. So you are committing to giving the drugs based on clinical data. So clinically, a tumor might be T3N2, but in truth, it may not actually be that when you actually get into it surgically. So we are committing to a clinical ascertainment of extent of disease. It's also a little harder to decide what to do with residual disease. If you've given all the drugs that you know are good, quote unquote, and the patient still has a lot of disease left, you're not entirely sure, and there's studies addressing this, but it's a little uncertain what to do next. And it's certainly a more uncomfortable position for the medical oncologist and the patient to be in than when you're giving adjuvant therapy, where it's all in a black box and you don't actually know what's going on and whether the drugs have had any success in eradicating the tumor, with the assumption that what's left in the breast is a proxy for the micrometastatic disease, which I'm going to talk about. That, of course, engenders what I'm going to call the temptation to use creative oncology, which is to start throwing drugs that have not been validated or tested in this particular setting just in order to do something. There's actually a little bit of data in triple negative that you can intervene with one drug, but there's really, in general, not a lot of data. And then, of course, the local management strategies that have been informed by thousands of patients participating in adjuvant trials becomes a lot more uncertain once you've changed the order. So can you omit radiation if a node-positive patient becomes a node-negative patient? What algorithm do you use? Do you use a node-positive algorithm or the node-negative algorithm? Similar, can you omit axillary dissection, node-positive becoming node-negative? These are actually topics of active research. So now what about the reason that people like the neoadjuvant paradigm for trials? And that's this. It's prognostic, right? The results of the neoadjuvant therapy tell you something about how the patient is going to do later. So you can see here event-free survival and overall survival. This is from a large pooled analysis that was done by the FDA, right? So the FDA actually endorsed neoadjuvant trials for registrational trials in triple-negative and HER2-positive disease based on these kind of data in order to accelerate drug development. And the reason is you can see event-free survival and overall survival are substantially better in those patients who have had pathologic complete response, meaning eradication of the tumor by the drugs that were given. So that's a surrogate endpoint for relapse and survival, and that's how it's used. So what that means, of course, is that it's been widely endorsed with lots of drugs and lots of regimens, because this is now kind of, if all you have is a hammer, everything looks like a nail, and this is now how we approach things. And I'm going to talk a little bit about how we get ourselves into trouble a little bit. I actually, listen, I'm a trialist, and I helped develop both of those CLDP trials, but we also have to recognize when we're getting ourselves a little bit ahead of ourselves. So this is why it's been so interesting. This is the problem we have in early breast cancer. It is a really nice problem to have, but this is our traditional model. So here's our clinical trials. You have a great idea. you test it. It either works or it doesn't. Whatever works in the first trial becomes the backbone for the next new idea and the next new idea and the next new idea. Now, if you put that in context of breast cancer, here's an example of a series of CALGB studies. And the CALGB was, I think, very forward-thinking. This is in the era of Larry Norton and Hy Mus as chairs, where they basically did exactly that with a series of adjuvant trials. In this case, I'm looking at just the chemotherapy trials, where the first one optimized the anthracycline, then they took the best optimized anthracycline, dose and schedule, they added a taxane, yes or no, that worked, so then that became the new backbone for optimizing the schedule, specifically the dose-dense schedule that everybody's familiar with. That's great, and that transformed and clearly was enormously beneficial for our patients. The however is, it took 10,000 patients and decades to answer 3 questions, right? So that's a problem. They're very slow and they're very big. We can't do this anymore. So we now know that breast cancer isn't one thing. So now you have to ask much more focused, appropriately focused tests within subsets. We don't have to have one good idea at a time, right? You can't spend a decade on one drug question. Also, it's increasingly clear that it isn't a one drug question, it's a combinatorial strategy question, right? And then, of course, again, this is definitely in the category of a nice problem to have. All of our patients are doing better, right? Because of the advances of the past years, breast cancer relapse has gone down markedly in the last couple of decades. That's a great thing for patients, a great thing for me as a treating doctor. For me as a clinical trialist, that means I have to design much bigger studies to answer the same question, because in the adjuvant setting, the only informative group are those that relapse, right? So now you're comparing relapse risk within control and interventional. So if the relapse risk goes down, the trial goes up. So this is where neoadjuvant, here you can do smaller trials, so it typically takes hundreds, not thousands of patients. You get an endpoint in a few months. You can get biomarkers, right? That's like, the question is not always did the drug work, but in whom, right? We have to be much more precise about these things. In the neoadjuvant setting, you actually can see in whom. But you have to know this is not where you test your first-in-human drugs, right? And I see this a lot in people who are relatively unfamiliar with the paradigm, who come with this, like, I got this great drug, and it's been given to 10 people, and I want to test it in a neoadjuvant patient. Well, you can't do that. You might kill the patient with the drug, and the patient has an 85% likelihood of being cured with just regular drugs. This is not a place for totally novel drugs. You got to know they're safe. I'm going to talk about this a little bit. Different subtypes of breast cancer react differently to the same drugs. So if you ignore that, then you can introduce a lot of confounding of the endpoints of your trials. And then, of course, I'm going to talk a little bit about this, like, how good is PCR as an endpoint, really? It's good, but it's not awesome. So back to this is that same Cortazar Lancet paper that pooled the analysis to try and get a very strong look for the FDA's purposes at what the relationship was. So, okay, so I'm a clinician. I've given my anthracycline taxane-based chemotherapy or my TCHP, trastuzumab and pertuzumab-based therapy in HER2-positive breast cancer, and they have residual disease or they have PCR. What exactly do I do? Do I know, does that change what I do subsequently, right? Do I know, for example, that in a residual disease patient that if I intervene with something else, it will matter? Conversely, if they are a PCR, can I omit the trastuzumab that I was going to give adjuvantly for a year, completing a year? Well, we don't know that you can alter anything. This assumes that you gave exactly what you planned to give. So I think the idea of tailoring using this is a really newer one, and one that's still being locked down. The second part is how good an intermediate endpoint. Well, you don't have to work too hard to see that of those that have a pathologic complete response, there's a relapse rate. All right? And of those who don't have a pathologic complete response, there's many who are, in fact, cured using that nomenclature. So that means there's noise in the system, and we have to acknowledge that. And the other thing is, the majority of our patients are actually hormone receptor positive, HER2 negative breast cancer. We haven't talked about that up to now. The fact this is PCR is an irrelevant endpoint in those patients, not because it isn't relevant for PCR. If you achieve a PCR, that actually confers a similarly good outcome in hormone receptor positive, HER2 negative. They just don't typically get PCRs to anything you give. That's a biology of the disease. We need a different endpoint. I'll talk about that. So, summary for right now as we launch into the next part of this. So PCR, and this is, I keep saying this to trainees, oh my God, we got to get to PCR. Let's give, patient isn't at PCR, let's give something more. PCR itself is not clinically meaningful. It's a microscopic finding. It doesn't matter to the patient. It doesn't matter, to me outside of the stuff we were just talking about. It's not a clinical endpoint. Now, and the relationship of PCR to outcome is clear, right? I just showed you the cortisol, and this is, every one of these studies has a very similar relationship, some degrees that I'll talk about, but none of them say it's the other way around. But it's hard to quantitate, which means it's hard to apply prospectively in a way that you want to. Namely, you want to do a neoadjuvant study and say, I don't need to do a confirmatory adjuvant study. Okay, so this is where I get to quiz you guys. So true or false question. A US Navy study found that the likelihood of death from falling overboard is higher if the sailor is wearing a life jacket. Who says true? Who says false? Who says you got to be kidding me?
I'll say true.
Okay, that's true. Who's heard of Simpson's paradox? So the statisticians, there's clearly no statisticians in the room, the statisticians say, well, yeah, right? The reason that the US Navy study found that you're more likely to die if you're wearing a life jacket is because, those of you who said true, what is it? Because the Navy mandates to them when the weather gets bad, you have to put a life jacket on. So this is the problem of causally associating things when you're missing an important variable you don't know about, right? So the study didn't take that into account. You have to take that into account. If you don't know to take it into account, you don't, and you end up with very difficult to interpret endpoints. That's called Simpson's paradox, which is when causal relationships are confounded by an unmeasured variable. So let's talk about pathologic complete response. So Don Berry, who is the longstanding CALGB head statistician, and Cliff Hudis made a run at trying to say, at what point does PCR translate reliably into an event-free survival advantage? This must be modelable. This must be mathematically knowable. And they came up with this based on the studies that were in hand with sort of a relationship as your PCR delta between the control arm and the investigational arm went up, the likelihood of that translating also went up, and here's the model, and it's a smooth kind of curve. This was me saying, yeah, but, so I actually layered on a bunch of existing trials that had event-free survival. Again, none of these are powered for this endpoint, but it gives you a hint that there's a lot more noise, as suggested, than we'd like. But there is clearly a relationship. It's just hard to say, if you get this hazard ratio or this PCR delta, then if you do an 800-patient study, you'll see an advantage. If you look at it a slightly different way, what odds ratio of PCR advantage, when that question was tested in a completely independent, properly powered adjuvant study, panned out? And you can get some sense, and I have here this is like me, many of these had odds ratios. I have estimate because when they didn't, I just sort of did a back of the cocktail napkin one. So it's, consider that. But fortunately, there's no statisticians here to throw things at me. So if you look, you can see as the odds ratio goes up, you're more likely to see a benefit in the appropriate adjuvant study. So for example, giving trastuzumab to HER2-positive breast cancer was tested in NOAA. It blew away the control arm of chemo alone, and it's been, we all know it's blows away non-Herceptin-containing adjuvant studies also. On the other hand, bevacizumab in triple-negative breast cancer had a statistically significant but much more modest impact and failed in the adjuvant setting. I'm going to talk about the HER2 setting because it's much more heterogeneous, but this is something we have to keep in mind. So again, I'm contractually obligated to show a intrinsic subtype heat map as an employee of the University of North Carolina. Here it is. So we think now of breast cancer from certainly clinical subsets, but also increasingly the molecular underpinnings of those clinical subsets. This is not in a supervised way. This isn't having to do with outcome. This is simply if you test breast cancers according to biology, what do you see? You see that they naturally segregate themselves into definable groups. And in fact, the basal-like one that's red, when they did what's called the PanCan analysis of the cancer genome atlas, and many of you know this, when they actually did that analysis, basal-like breast cancer isn't even breast cancer. It's like separated from all the other breast cancers, meaning it's really biologically distinct. That means that the testing hypotheses and the backbone for what we do also varies within these groups. In the hormone receptor positive luminal groups, these are really endocrine-dominated biology, and they seldom have PCR no matter what you throw at them, including anti-estrogens. Chemo-based for the triple-negative ones, and of course HER2 targeting has to be the backbone for what we do in anything that's HER2 positive. So let's take them piece by piece. So neoadjuvant therapy in HER2 positive disease. So I'm going to talk about dual therapy because it's instructive, and it is the area where most of the studies, the big enough studies for interpretation, have been done. Pertuzumab, for example, was tested and FDA approved. This is the unusualness of this. A couple of years ago, pertuzumab was approved for use in early breast cancer, specifically in the neoadjuvant setting, based on these two studies where they took polychemotherapy trastuzumab, also known as Herceptin in the drug company name, and they added or didn't add pertuzumab in Neosphere, and then Trifina actually just looked at what's the best backbone. And looking at the PCR rates, you can see very high PCR rates in the randomized trial, substantially higher than any drug. The THP outperformed the control arm of TH. Intriguingly and importantly, if you omit the chemo, it underperforms. Chemo's not going away, so we have to think about tailoring chemo also. And then very high rates in Trifina. Now, on the basis of this, pertuzumab was endorsed by the FDA for neoadjuvant therapy. The NCCN said, the timing of surgery is irrelevant here, right? That shouldn't be a variable. So the NCCN guidelines subsequent to that basically said, if you're going to use it neoadjuvantly or adjuvantly, you may consider pertuzumab to be added into any of the following regimens. It's fine. It's a $100,000 worth of drug, so we have to consider precision here. So let's go back and look at the dual therapy HER2 questions. So pertuzumab was tested in Neosphere. That's the one I just presented to you, and that's on the far right. So that tested pertuzumab, and you can see the chemo trastuzumab in light blue. The chemo trastuzumab plus pertuzumab is in the dark blue. It's unfortunate with the Duke Carolina game coming up that I chose that color scheme. But if you look at the other three, there were a series of very similar trials testing a different drug, lapatinib, HER2 small molecule inhibitor. Pertuzumab is a monoclonal antibody. Also, as you can see, the consistency here is that in each case, if you add a second HER2 targeted drug, you get higher PCR rates. Sometimes it meets statistical significance and sometimes it doesn't, but numerically it's always in favor. And the ones that are dotted are the statistical ones. So you see a consistency of effect, but at varying magnitude. So why is that? So if you say, well, what are the differences amongst those trials? Well, hormone receptor status, extent of chemo, size of trial, duration of treatment, there's a bunch, including significance of results. But let's dive down a little bit further. Now, 3 of the studies I showed you, 1 of which was significant and 2 of which had a numerical advantage that did not reach statistical significance, were with lapatinib. Lapatinib was tested in an adjuvant trial, a large, I can't remember, it was like 5,000 patients, actually 6,000, I can add up the numbers, in the adjuvant setting, and you can see, not much of an impact. If there's an impact, it's between around 15%. Maybe that's notable, maybe it isn't. To get a significance out of that would take a much larger trial. And so, in a sense, lapatinib failed in the adjuvant setting for a clinically meaningful endpoint of event-free survival. So why? So let's go back to NeoAlto. So NeoAlto was the significantly different PCR difference. So this is one of the 3 trials where it had about a 2.5-fold odds ratio in favor of adding lapatinib. so dual therapy. Here's the overall event-free survival in that study. Again, these are not designed to be adjuvant, so this is a look, but not a definitive answer. But you can see in that study, it looked like there was an impact that was emerging in the parent trial. And if you broke it out at least by hormone, these are clinical hormone receptors, this is not molecular biology, you can see that that appears to be driven by the HER2-positive patients that had tumors that were hormone receptor negative. The tumors that were hormone receptor positive and HER2 positive seem to benefit far less. Now, Neosphere, so here's the one with pertuzumab. Again, these not statistically significant, but a hint that pertuzumab is going to be outperforming a arm that excludes it. There is a large trial pending, but I think the kind of analysis that we're doing right here actually will help inform the results of APHINITY no matter what it comes up with. So CLGB 40601 is one of those CLGB trials. This was the HER2 positive one I mentioned earlier. This is the design and the schema of it. Everybody got weekly paclitaxel. That was the only chemotherapy. And they either got lapatinib, trastuzumab, or both. The other thing that we did is we required research biopsies of every participant in the study. This was controversial at the time, and in fact, some of the cooperative groups, including ECOG, actually, their patient advocates declined to let them participate in it because they felt that was coercive. I think actually, I disagree. That's a wonderful conversation we can have. But in this setting, for this study, we required everybody had to have a biopsy because we wanted to co-report the clinical endpoints and the correlative ones. We didn't want to wait. So here's the results of the actual trial. You can see overall there was a numerical advantage to adding the dual therapy of about 10% delta between adding dual versus single HER2 therapy for the conventional arm. And we saw the same thing that they saw in Neosphere, that it differed enormously whether the tumor was HER2 positive and hormone receptor positive or HER2 positive and hormone receptor negative. So if you look at the molecular underpinnings, we start to get a sense of why, and this gets back to that Simpson's paradox of what you're not measuring when you do these trials. So if you take all HER2 positive breast cancers, which is a clinical bin that we're all familiar with, there's actually a lot of molecular heterogeneity amongst them with, in this particular data set, about a third were HER2 enriched, about a third were luminal A, which is our best prognosis subset, typically has strong influence of hormone receptor related pathways. And then another third was luminal B, still dominated by estrogen receptor related signaling, but to a far lower degree than luminal A and with much higher proliferation influences. If you break it out by receptor positive, receptor negative, you start to get a sense of where this can play out and why this might be important. Hormone receptor positive, HER2 positive breast cancer was largely dominated by luminal subtypes. Hormone receptor negative HER2 positive breast cancer, the simple majority was actually a subset called the HER2 enriched subtype, where the driving pathways from a molecular standpoint are in fact HER2 related far more than they are luminal related. There's still, and this is one of the complexities of our lives, you see all the subtypes when you do this, and in all of our studies, you see a small but real part of subtypes that you didn't expect to see in there, like basal-like subtype. We really shouldn't see a basal-like subtype in a HER2 positive breast cancer, but you do, right? That's the problem with clinical assays, don't always represent biology faithfully. But just this simple look of the luminal versus HER2 enriched gives us a lot of information. Now, what about where the rubber hit the road in terms of PCR? Well, it played out. So as you can see here, and basically the overall parent study is the one outlined in red, and then all of the arms are in their individual bar graphs. Regardless of arm, if the tumor was HER2 enriched, the PCR rate was higher, period, right? So we were seeing a 70+ % pathologic complete response rate, which is really high, with 12 weeks of paclitaxel and trastuzumab. So that's cheap. And it's not particularly complicated. It's akin to what we give in what's called the APT trial. So those of you who are medical oncologists taking care of breast cancer patients, we now have endorsement of a very simple regimen we give to stage 1 adjuvant patients, which is just 12 weeks of paclitaxel and a year of trastuzumab. In this case, it was 16 weeks of paclitaxel, but the point is well taken that you can maybe tailor de-escalate therapy if you know that the tumor is highly sensitive. That's a testable hypothesis. And this may explain why we saw this differential, and the neo-alto people saw the same thing in Europe between hormone receptor positive and hormone receptor negative and positive on clinical assays. So what else weren't we measuring? So this is the beauty of when you work closely with scientists, they start doing discovery. And so one of the clear implications in breast cancer, particularly HER2 positive and triple negative, is that there is a big prognostic impact of tumor infiltrating lymphocytes. That really matters. We looked at immune signatures, so we didn't do microscopic. We did RNA-based signatures. These are all prefab signatures that had already been published that we tested. I can tell you, we tested 5 of them. They all worked, and they all covary enormously. So I'm showing you one of them, but it really didn't matter. All of them had a significant impact, again, regardless of what drugs I was giving, a significant impact on whether the patient achieved PCR or not. I'm throwing this in because it's kind of interesting. This is actually stuff we just sent to ASCO. It's a window of opportunity trial where we just gave varying kinds of HER2 targeting, no chemo, for a short window, 1 week. 1 week. So 1 week of HER2 targeted therapy. And actually, we were looking for kinome reprogramming of HER2 related kinases. And we'll talk about that, not here, but at ASCO. But what the scientists who were doing this said, yeah, it's a funny thing, but while we're at it, actually the biggest kinases that we saw changed actually weren't the tumor cell kinases, it was the immune cell kinases. This was 1 week of just HER2 targeting, which I thought was pretty interesting. So when you put that into the mix, you say in multivariable analysis, what mattered, right? You can see that treatment mattered to some degree, but it's pretty puny in terms of impact. The biggest impact is by not using a really inferior drug. All the other stuff was actually relevant and arguably even more relevant. So I would say that even within a clinical subset, we should recognize that response to therapy, we're using a neoadjuvant model because that's where we get some data, but this is true in the adjuvant setting too. PCR and response and event-free survival and outcome are going to be affected by the drugs we give. Okay, I'm not going to downplay what I do for a living, but genetics of the tumor, and the microenvironment. And I think we ignore that at our peril. So how does this play out in event-free survival? NOAA, going back to that original chemo with or without HER2 targeting study that was done by the Italians 1,000 years ago, they went back and looked at this in their data set. It's a small study, so there's limits to what you can say, but it's very, very consistent. So what you see is HER2 enriched versus everything else. You actually do see an augmentation of pathologic complete response if you go from no HER2 targeting to adding a HER2 targeted drug, first generation HER2 targeted drug. The key part here is if you then look at event-free survival. Remember, NOAA actually had a statistically significant impact on event-free survival. The studies I was talking about are dual therapy versus single therapy. So we're gilding the lily within an already impactful regimen. This was asking the does HER2 targeting work question. It obviously does. In that group, the impact on event-free survival was really driven, as you can see, by the HER2-enriched subtype, where HER2 targeting is really the key element, and effective HER2 targeting is the key element in outcome. In the non-HER2 enriched, which are again mostly luminals, it became far less important. Neo-alto went back and looked at these same things. I can summarize this by saying they found very, very similar impacts on pathologic complete response in neo-alto, which is an analogous European study to the CALGB one, with immune influences, intrinsic subtype influences, et cetera. When they looked at event-free survival in that study, some of those remain significant, but then you start adding in a bunch of other stuff, particularly things that are relevant for luminal endpoints that are not related to HER2 targeting. Right? So we just have to keep that in mind. And actually, we're looking to do a pooled analysis to try and get these a little more locked down quantitatively. But it's going to be really important for us to do this. Otherwise, we're going to be fooling ourselves with neoadjuvant trials as we make assumptions about adjuvant endpoints. So what about triple negative? There's been a bunch of triple negative targets, right? The problem with triple negative breast cancer is we got chemo, we got chemo, we got more chemo. So there have been targets. These are putative targets, and I'm just using them as examples because they were the things that were tested rigorously in the neoadjuvant and the adjuvant setting, particularly DNA damage response dysfunction, which brings up both PARP inhibition, which I'm not going to talk about today because the data are less mature, and platinums, and then the idea of hypoxia and hypoxic signatures and VEGF. So platinum responsive and triple negative, we have a number of trials that tested this, large cooperative group studies. You can see that outside of a relatively small Spanish trial, there was a significant increase in pathologic complete response if you add another drug. So we go from 3 drugs to 4 drugs, specifically a platinum agent in triple negative breast cancer. So how about event-free survival? Because this is important because triple negative breast cancer, unlike HER2 positive, hormone receptor positive breast cancer, you're not giving adjuvant anything typically. These patients, once they finish this chemo, they were done with systemic therapy. So it's really a purer model. So what's the impact? So in GEPAR-6TO, which was one of those, a triple negative subset of a relatively large study, about 300 and change patients that were triple negative, you can see an actual impact in disease-free survival emerging. On the other hand, in CLGB 40603, which was anthracycline taxane conventional therapy, much more modest, if anything, impact. You know, the curves are really close to each other. So if there is an impact, it's going to be pretty small, and you'd have to test a lot of people to see it. Similarly, bevacizumab, for the most part, there was a B40 study that had a subset analysis where it didn't seem to have much of an impact, but the large German study and our own CLGB study saw a significant impact, improvement in PCR with the addition of the anti-angiogenic drug bevacizumab. However, here's the however, when they tested this in a adjuvant trial, you can see that chemotherapy with or without Bev does not have much of an impact. If there is one, it's pretty modest. So what are the things that influence triple negative that we weren't measuring? So we don't have as much data at this point, although it's emerging, but you can see that certainly the immune signatures vary and are highly significantly influencing PCR. This is an emerging element and very important in triple negative. There's a reason that immune checkpoint inhibitors all started in breast cancer being tested in triple negative metastatic disease because of the importance of immune activation in outcome. So clearly immune-based stuff is important. It looks like low estrogen signatures. Again, these are all ER negative, but you can still have estrogenic signaling, and that also looks like it matters. So what about, let me just pivot to the last clinical subset, which is hormone receptor positive, which has been kind of ignored in everything I've talked about up to now because it's much harder to do and the endpoints are much murkier. So hormone receptor positive breast cancer. So first off, there is this idea that chemotherapy is more powerful than endocrine therapy, and that low response rates in hormone receptor positive breast cancers treated with neoadjuvant endocrine therapy is because the drugs are slower to work and maybe a little less quote unquote powerful. They need to be given longitudinally, et cetera, et cetera. I'm not sure that's true, and the reason I'm not sure that's true is there's a couple of data sets, this is just one of them, that said, okay, same clinical phenotype, who are typically just a subset of our neoadjuvant studies, because these are not the patients I typically would send for or preferably send for neoadjuvant therapy, aromatase inhibitor or an anthracycline taxane-based regimen. So decent chemo. And what you can see is the clinical response rate. There's virtually no PCR for anything in these patients, so that's why PCR is not an advantage, is not a useful endpoint. If you just use clinical response rate, you can see it's the same. It's not the drug, it's the biology of the tumor. And in truth, if you have strongly hormone receptor positive, like the ones at the far end of the curve in terms of how hormone receptor positive they are, it actually looks like you're better off with the anti-estrogen than you are with the chemotherapy. So if we can't use PCR, what can we use? I mean, how do we tailor in this setting, and what's a better endpoint? So that's actually been the subject. The Europeans, particularly the English, who don't like to give chemo nearly as much as we do, have been tilting at this windmill for a number of years. And then Matt Ellis, who's technically American, but he's a Brit. So he's been pursuing this to a large degree also. This is called the PEPI index, or preoperative endocrine prognostic index. And the group that developed PEPI, which was Matt and a guy named Mitch Dowsett over in England, really did something I thought was very smart. They said, let's take some clinical variables, but let's also look at pharmacodynamic endpoints in the tumor. So let's see if we can look for an impact in the tumor on whether or not it's going to remain endocrine sensitive, and let us omit chemotherapy in these patients. And the key part of this is Ki-67. In fact, ER status doesn't seem to add a lot to it. So in the modified PEPI, it's really just, is proliferation low or not after you've given a few weeks to months of endocrine therapy. And the truth is, if you give just neoadjuvant endocrine therapy, by PEPI score, the group 1 are the best, the ones that have done the best from a PEPI standpoint, meaning the tumor was not wildly clinically extensive, and the driving part of this is Ki-67 was low. And they did great. They did great in IMPACT, which was their validation data set, without chemo. There was no chemo given to these patients. So this is now being studied as a real endpoint. Can we omit PCR and instead have something valuable and validated in hormone receptor positive, HER2 negative breast cancer in order to help us omit chemo and test drug regimens? There's a cooperative group, intergroup study called Alternate. I don't know if you guys are participating in it, which is exactly that study. It's about half accrued now. So what are the new directions that we're doing? Well, so I told you about residual disease, and can you leverage our understanding of the prognostic implication of disease that's left over? There's a couple of ways you can do that, and there's trials using both of these, although particularly the one on the top, which is either go to surgery, you know for sure whether there's residual disease or not because the patient's gone to surgery, and there is. And then you can intervene with a new regimen or an old regimen that you're testing in this setting. This is where CREATE-X, so some of you may know CREATE-X is a triple negative, it was not a triple negative, it was a residual disease trial, but particularly in the triple negative subset, intervening with capecitabine after chemotherapy neoadjuvantly actually seemed to improve outcomes in a subset analysis that's triple negative. It hasn't been published yet, although I think, as I understand it, it's currently under review. So the nice thing about this, and this is also where there's a SWOG study coming out that's going to be a pembrolizumab study. So it's looking for that immune activation question. That's going to be emerging in triple negative, et cetera, et cetera. The pros, you know for sure whether this is the traditional approach. You know that they have elevated risk, right? You've taken that out. So now you can do a smaller study because you're enriching for a higher risk population. You've taken away the ones who are going to do great from conventional therapy standpoint. The con is you're now back to an adjuvant trial. You don't have any tumor to measure. You don't have any tissue to collect. And you have to power it for that adjuvant subset. There is the idea that you should then leave the tumor in place if you know there's residual disease, and then do a second neoadjuvant randomization. The I-SPY trials to some degree have done this. That gives you tissue still to access, the ability to measure it. You can do a much smaller study. The however is you have to be sure that you actually have residual disease, right? Do we know for sure? Do we have an imaging or other methodology to know whether there's residual disease? And it does, potentially complicate surgery depending on the impact of the second set of drugs. We know whether we interfere with surgical endpoints. If the novel therapy is really bad, and the tumor progresses, or if it's something like bevacizumab and you have higher surgical risks, that needs to be taken into account. So how good are we at identifying pathologic complete response without going to surgery? It turns out we're actually not that good. And this is a ripe opportunity for imaging and other correlative analyses that haven't yet been done. I'm going back to that CALGB, the surgical endpoints of those two neoadjuvant studies. So remember, pre-therapy, is the patient a breast conservation candidate or not? 51% of them, they said no. Afterward, they said, are they a candidate now? And in 58% of the time, the surgeon said, nah, they're still not a candidate. And most of that was because we asked them why, and they said because the tumor's too large or the cosmetic result will be inadequate because of the extent of tumor I'm going to have to take. Those are the two main responses to that. which would be fine, except 42% of them actually had a PCR. So the clinical and radiographic evaluation of extent of disease clearly failed because 42% of these patients actually didn't have any invasive cancer. They might have had DCIS, that was about 8% of them. But it's still most of them, we aren't that good at assessing it. So we need better methods. So I'm going to circle back around to my friend and colleague, the surgeon, who did the staging sentinel, and which he loves to do, and he said, I think we should do neoadjuvant therapy so we can see whether the drugs are working. And listen, I'm an aficionado, I give a ton of neoadjuvant therapy, but we also have to be very, very honest about what we're trying to accomplish. And so we may find out if the drugs are working on the tumor in the breast, but we won't know why for all the reasons I just outlined. At the moment, we won't know what to do with the information. There isn't a tailoring algorithm for this. There's a roadmap for it. I think we know what we need to do in order to get there. And in this particular case, the patient was going to have a mastectomy anyway, so it wasn't going to help with the one thing I know that neoadjuvant therapy can help with, which is surgical minimization. So how do we conclude? So the neoadjuvant approach is clearly advantageous. It is a favored way of doing this. It's way favored for large or inoperable tumors in whom the surgeon could use a little bit of help. Can we do that better? Can we leverage that better? Can we identify residual disease and non-residual disease better? The trials have advantages. They're clearly advantages. That's why there's been this explosion, right? They guide larger definitive trials. You can do tissue-based studies, which I would argue is absolutely key for us getting smarter about this and doing anything that's interpretable. We're really good at adding drugs. We're not that good at tailoring or reducing or de-escalating. And I think outside of these kind of approaches, I don't know how we do it. And both responsive therapy and outcome are multifactorial. And sometimes the factors related to the drugs that an outcome at surgery are different than the outcome 5 years later. And we have to have a plan for how to incorporate them better. And a lot is riding on this because we can't go back to the traditional way of doing things. So I think this is where we have our biggest challenge, but there's a lot of smart people thinking about it. Thank you.